Okay, we talked this morning about COPD in general. We talked about PE, about the use of things like markers like the BNP, what you do with troponins, and we talked about beta agonists, anticholinergics, and steroids. And to be honest, we covered the vast majority of the information you need to know about managing COPD. There are two and a half other sort of big things that might be in your armamentarium to treat somebody with COPD. The first section we're going to get into here is the idea of antibiotics. Okay, so we're talking now about this sort of next step, which is antibiotics. Now, I was upstairs while you guys were off skiing, I was upstairs and I pulled up that gold criteria I told you about. But you get one free download, and they start charging, because of course the world needs to charge for everything. But you get one free download of their guidelines. And I went through it to sort of see what they recommend on these things, just to make sure I was telling you the correct stuff. And the quote they say as far as antibiotic use is, if a patient has an exacerbation characterized by increase in dyspnea and sputum volume with, quote, purulent, unquote, sputum, you should consider using antibiotics during that exacerbation, which I think is not unreasonable. But the first two papers in here do raise a little bit of an eyebrow about what does purulent sputum actually mean. By the way, we deal with a lot of body fluids in medicine. One of my least favorite is sputum. Any body fluid that like sticks and stretches is just kind of gross. Sputum is nasty business. And if you ask a person to give you sputum, what they tend to do is go, pfft. I mean, they give you spit, right? If you want sputum, first of all, sputum needs to be from down here. So they got to hawk up a good one for you. They have to do that horrible old man down the hallway, to get it out of there, to get you sputum that's really sputum, right? That's what they really need to do. And then, and think about the patients that come in and, I love the ones that hand you the tissue. Here you go, doc, this is what I'm coughing up. Or give you the emesis basin with like the last 12 hours collected in there of what they've managed to gooby up there for you. Part of this is what they call bad, sputum, icky sputum, purulent sputum. Is that what you would call purulent sputum? And what does it mean? And the first two papers try to look at this. And to be honest with you, I think these are entertaining. I'm not sure it's going to help me a whole lot in what I decide to do with a COPDer. But they basically try to divide sputum in the first paper into mucoid sputum versus truly purulent sputum. God bless them, they got a paper out of it. Good for them. They did find that if somebody really has truly, they're coughing up pus, there are bugs in there. That's helpful. If it was mucoid, they were less likely, but have at it, good for them. The second paper basically said that if they do cough up what looks to be, sort of a different color change from what they're used to, that it doesn't necessarily imply a significant bacterial load. It does often imply an infection, which is what we're going to transition into next. So remember that what people are coughing up when they have COPD, when they cough up stuff, they've got inflammatory changes down there. What triggers that particular exacerbation is frequently an infection, and it may or may not be an indication of bacteria, okay, which is fine. That's fine. So that's the general gist. Somebody got publications out of dealing with that stretchy, icky, sticky body fluid. Now, do respiratory infections actually cause COPD exacerbations? You all know they absolutely do. Flat out, no question, infections cause exacerbations. In fact, in the United States, the reputed two most common reasons people have COPD exacerbations are infection and smog. Okay, so if you happen to live, weather changes where suddenly the wind is blowing and the smog is all there, or the wind is not blowing and the smog is all there, tend to cause exacerbations, and they do. The question is, what bugs? If you have infection that's causing you to be exacerbating, what bugs are they? And I tell you, abstract number 37 will probably never be done again, because it was so flippant expensive to do, but is a really interesting paper that says, what bugs? What they did in abstract number 37 is they took 213 patients with 214 exacerbations, and they did a panoply of ID tests. They did acute and convalescent serologic titers for things for which you could do that. They cultured for things like viruses. They did tests for the atypicals. They tested for something like 13 different organisms, so 13 different respiratory pathogens. No one will do this kind of study again. No one. But it is really helpful to know that someone did to tell us, what do they really have? If they have an exacerbation, what's in there? Well, what do you think was the most common thing they isolated? Most common type of thing? Viral, flat out, half of them. Half of them were viral. What was the second most common? You'd think it'd be strep pneumonia, or you'd think it'd be H flu, because they lied to you in medical school. They told you that's what they all have down there, right? In medical school, they said COPDers have little, parties of H. flu and pneumococcus going on down there because they just live down there. And they do, but not as commonly as atypicals in exacerbations. Viruses were about 50%. Atypicals, which include Mycoplasma, Chlamydia, and Branhamella catarrhalis, which is now Moraxella catarrhalis, that was in about 30%. And what we think of as typical bacteria was about 23%. And there were some patients that had overlap, which makes sense too. Some patients had overlap. This I find very helpful. This gives me an idea, and the reason I find it helpful isn't in what I'm going to choose to treat them with. What I find it helpful in is not to be disappointed if it doesn't make them a lot better. Or not to be disappointed if the papers say you get an incremental benefit, but it's not super exciting. Well, that makes sense. If half of them are viral, we would still like to catch the atypicals and catch the typicals if the other half have that. But I shouldn't get all my excited if I'm giving antibiotics and expect them to suddenly walk on water and breathe beautifully. They just don't. So I think that was very helpful to have that study done. That's kind of useful. The other thing that's useful in that study is that you need to then cover for atypicals when you pick a bug juice. If you're going to pick a bug pill, that bug pill has to cover the atypicals as well. So not to focus on the stuff they taught you in medical school, which is the H. flu pneumococcus, which is down there, but to also make sure you're covering for atypicals when you pick something. And you don't need to pick a gazillion-dollar drug. There are some drugs that are relatively inexpensive that work to cover that range of bugs that are out there. So you want to cover H. flu, strep pneumo, Moraxella catarrhalis, Mycoplasma, and Chlamydia. You can choose anything from an oral beta-lactam that has that spectrum, a respiratory beta-lactam, a tetracycline derivative, but there aren't a lot of great ones of those out there, a respiratory quinolone, which I discourage you to use, save those for the sick people, advanced generation macrolide, so you can use something like clarithromycin, that works fine. You can use Bactrim, cheap, inexpensive, works great. So you have a lot of cheapo things in your armamentarium that you can use to cover what we now know is what's down there if somebody's having exacerbation. So I thought these papers were helpful. And the key is don't use a gazillion-dollar drug. And I really, really want to discourage the use of a respiratory quinolone. Bugs are really smart. And they look at quinolones for a while, and they shrink and die. And then after a while, it's like, I am a chromosomally mediated, I can actually be resistant to you. For instance, gonorrhea, forget it. You cannot treat gonorrhea with a quinolone in the United States anymore. Forget it. Can't do it. Doesn't work. It's way too smart. In fact, up to half of isolates now, depending where you live, are resistant. Quinolone resistance emerges very quickly. Save the quinolones for the really sick folks. So use the cheapo stuff in this particular group. And should you use them? I believe yes. And the literature basically says you get a small, not fabulous, but a small incremental benefit from adding antibiotics to that COPDer who's exacerbating. So I think it's worth adding. Not exciting. What is exciting is non-invasive ventilation. How many of you use non-invasive ventilation in your acute care setting? Hands high. Okay, this is great because we've been talking about it for a while. We didn't actually have it at Harbor until we basically had to go to, well, I'll show you the paper. We had to go to administration and say it's worth the money. We showed them why in a paper that's in here. But 5 years ago, maybe 5 hands would have gone up in here. And 7 or 8 years ago, no hands would have gone up in here because the respiratory therapists and the pulmonary department kind of hid it. And it was like their thing. They kind of hid non-invasive ventilation. And I'll tell you, as far as COPD is concerned, it is truly a lifesaver. Truly, flat out a life. We all know we're always hesitant to intubate a COPDer. Not because it's that hard up front to do. Heck, we can all intubate. That's not that hard. But upstairs, getting them off that machine is a nightmare, an absolute nightmare. We would like to not have to put the tube down. Does non-invasive ventilation give us that? Absolutely. Several papers in here. Bouchard's is the first one, and Bouchard is actually one of the sort of first big proponents of using non-invasive ventilation. He's French. Non-invasive ventilation for a lot of emergency treatment stuff. Very big proponent. A lot of the original literature came from Broussard. Abstract number 45 looks at in the out-of-hospital setting, which we talked about on the panel yesterday. Using this in the out-of-hospital setting is great. Abstract number 44 is 15 trials. It's a meta-analysis that tells you what you get for this. What you get is a 28% decrease in need to intubate. 1 in 4 that you would have otherwise intubated, you will not intubate if you use non-invasive ventilation first. You get a mean decreased length of stay of 4.5 days. I have a hospital with a 12-hour waiting time to get to see me. I would like them out on that end. I'd like them not to be in for a long time on that end. That is fabulous. A 10% decreased mortality rate overall. 1 in 10 that would have died from that exacerbation doesn't. That is huge. That is absolutely huge. Enormous benefit on all measurements on this particular thing. Failure rates, quite low overall. Number needed to treat, which are always kind of helpful numbers. To intubate, you need to only treat 5 to save 1 intubation. As far as complications overall, you only need to treat 3. And mortality, you only need to treat 8 with non-invasive ventilation. Any single digit number needed to treat is a strong number, and you've got them on every measurement when it comes to non-invasive ventilation. It's very useful. And I can't remember which paper it is in here. I've got it flagged somewhere. One of them basically talks to you of how to go to your administrator and say why you need these machines. If you don't have them and you want one, the money savings is astronomical to have one of these things. It pays for itself in 2 patients. 2 patients. The thing pays for itself. That's how we convinced our administration to buy us our own machine. What settings do you all use when you use it? COPD comes in, what setting do you use? First of all, do you use CPAP or BiPAP? BiPAP. BiPAP is really probably the only instance where BiPAP is truly proven in the literature better than continuous. It's probably the only time that really you should, on purpose, choose BiPAP up front. What numbers do you tell your RT to set it? Got a 10/5, any other numbers? Got a 10/5, anything else? 8/4, 8/3, any of those are fine. Don't go over 10 to start. And what you're doing with non-invasive ventilation, for those of you who aren't familiar with it, and for those of you who are, bear with me, but for those of you who aren't, and I won't put you on the spot by raising your hand, but what this does is basically, I'll tell you where it evolved from. In Scandinavia, about 30 years ago now, there was a patient with congestive heart failure. They report this case, where the patient was refusing intubation, just didn't want anything done. So somebody took an ambu mask, literally, put it on the patient's face, took the tube from the ventilator, jammed it on there, and turned on PEEP, and held it there. And then eventually kind of taped it there. And the patient did great. It's like, wow, yeah.
Why do you say don't start over 10?
Isn't it because of the barotrauma potential? And you often don't need to go over 10, which is in contradistinction to congestive heart failure.
Is there evidence that says there's more barotrauma over 10?
There is, but it's sort of secondary evidence. It's not directly studied. So it's not something where they said, let's study, which the better for me to be able to give you a clear answer, it would have to have been studied with, we looked at these numbers specifically to see if there was an incremental increase. I think most patients do fine with 10/5 or 8/3. I wouldn't start higher. If you need to go higher, go there, but I wouldn't start higher because most patients don't need it. Don't need to go higher than that. Now to back up a smidgen on what non-invasive ventilation does is it is basically PEEP. And what it does to somebody's airway is it stabilizes their airway, it decreases workup breathing, and it helps diffusion capacity. And the reason that BiPAP is helpful in somebody who has COPD is what it's doing is every time they breathe in, you're giving them a little extra psh, and then when they start to breathe out, you take that extra PEEP level down a little. So you start at 10, they breathe in, the pressure increases at 10, helps them at 10. You have them breathe out, it drops to 5. So it's helping them stabilize their airways open and helping them with workup breathing. They do fabulously. The key to this is to start it early, which is why these pre-hospital settings are working so well. These pre-hospital protocols are working great. In fact, there are patients that the paramedics will say, honestly, they look like crap at home. They look great now. It was as bad as we said on the radio, but we stuck them on this thing and they look great now that we've transported them for 10 minutes to you. It works beautifully. And honestly, this is probably the single most important reason you should have non-invasive ventilation around. Yeah?
Is there any role for it in like the moderate or mild respiratory?
Good question. It looks like there is some potential harm in using it in mild to / moderate exacerbations. The most benefit is derived from the severe exacerbation. And the reason is that there is an effect on venous return by using this sort of thing, and there is a risk of barotrauma. So when the severes flat out use it. The moderates, see how they do. The milds, I wouldn't recommend it at all. And actually, there is evidence of potential harm in the mild to moderate cases. It's in one of the papers here as well. Yeah?
Is there anything in this in terms of how long, they should stay on it? I mean, what I see is we put it on down to the ER, we get them upstairs, and then that's the first thing that the doc wants to taper off. Let's get rid of the BiPAP as soon as possible, or the CPAP or whatever it is. In our hospital, it's BiPAP. And then,
The question is sort of, is there a guidline for taking it off?
In terms of like that 24 hours, like 48 hours that helps to stabilize things, but there's any continuing benefit, or is it just the benefit it gives at the moment in time?
Well, you're asking sort of a two-level question. So the question is, first of all, is there a protocol to take them off? And then is there any proven benefit of any longer duration of this? And that's a little bit of a split question. The off part, as far as the acute exacerbation, you can technically take it off as their blood gases get back to baseline and their work of breathing decreases. So their pH is okay, their respiratory rate's down to their baseline, and their blood gases are back down to baseline. As you taper it down, if they can stay there, it can come off. The flip side, though, is that there is some, for those of you especially that manage outpatient COPDers, there is some evidence that oxygen therapy will increase their lifespan, actually not just their quality of life, but also their lifespan. And there is a smidgen of evidence that there may be some evidence of CPAP also helping them as well. So it's a kind of a two-pronged question. For the acute exacerbation itself, it's when they get back to their baseline. And that could be quick. I mean, that can actually be while they're in the ER. That could be a very short duration that they may actually need it. Any other questions on non-invasive? It's really exciting. And this to me, and I'll tell you, Bouchard's editorial, which is the first one in that list, basically says this is the first-line therapy for an exacerbation. And even if you go look at the National Heart, Lung, and Blood Institute recommendations that they have in this, National Heart, Blood, and Lung Institute, and the GOLD guidelines, it's going every single time they're issued, it's bumped one step higher in the sort of what do you pick out of your armamentarium, it's getting higher along the list. So anybody who's bad, grab it, and the sooner you use it, the better. The other thing that's in here is Heliox. It's interesting. There aren't a lot of Heliox papers out there in either asthma or COPD, but there are a couple in here. There are 3 in here that look at this in COPD, whether you should be using Heliox. Now, Heliox comes in several different formulations. Most of it is in a 70-30 formulation. There's an 80-20, there's a 60-40, where basically what you've done is you've replaced the nitrogen in a room in a 70-30 formula, or an 80-20. You place the nitrogen equivalent with helium, and the rest of it is oxygen. 20% oxygen, 30% oxygen, 40% oxygen. And what you're doing in theory is taking this little teeny tiny molecule of helium, and it goes really fast through narrow places, much faster than nitrogen, which is kind of heavy and clunky. It whizzes through there and theoretically makes it easier, decreases work of breathing, helps oxygenation. And in some instances it does. Does it do it in COPD? The data is not particularly exciting in this. And the downside is that some of these patients are very oxygen dependent. So you've got to be careful if you get to Heliox levels that get to 80-20, where they might need, so they're a home O2 dependent person. They need that at home. And now you stick them on 80-20, you're giving them actually less oxygen than what their baseline is. So you have to know how this stuff works in the first place, what the proportions mean, and then does it really work very well? The data here is hardly compelling. Most of it, I know we don't have access to it, I think because it's entertaining. It gets used on night shift so everybody can talk like Mickey Mouse because it's kind of fun. So it's never, the tanks are always empty. We actually now keep them in the OR because they're always, the nitrous was always empty too. That went away a long time ago. Our nitrous has been long gone in our ER. It was always empty. I have no idea who might have used that. But so Heliox is not very exciting. It's unfortunate, but it would have been nice. The last couple papers in here look at optimizing therapy. Okay, we've talked a lot about COPD. The last couple, number 54 is a very nice paper that looks at sort of the optimizing therapy for acute exacerbations. It's a meta-analysis and systematic review that comes to the conclusion that it is what you all do every day. Somebody comes in with COPD, you grab a beta agonist, you stick them on an inhaled anticholinergic, you give them an oral steroid, okay, go ahead and give them their oral prednisone, you stick them on non-invasive ventilation, and you give them a broad-spectrum, cheap antibiotic. That's what you all do. That's what's recommended. It's what's supported in the literature as well as we can support it. The chronic treatment, which is not addressed in this, we also mentioned. Cholinergics are first. Okay, first-line therapy are for chronic. Beta agonists, a little bit of addition to that. Inhaled corticosteroids with the increased risk of pneumonia. And those of you that are office-based do this all the time. Somebody has that sputum change and a little bit of shortness of breath. They have the antibiotics. They can go ahead and start at home. So they can actually start to kind of try to take care of that at home. So that's the general management. Do we do this? No. Abstract number 55 is from Rita Sadulka, who actually does a lot of research in pulmonary medicine. She's an emergency medicine doc, great gal, who basically says, you ignorant sluts, you're doing it wrong. And she looks at elderly patients, and the data is kind of alarming. She said, here's the published guidelines. You guys all, they've been out there a long time. This isn't new stuff. And she basically said that our adherence at best is about 75%, and at worst is about 28%, and we're just not stellar in any of it, which also goes with what Kevin talked about with what we do with sepsis, et cetera. So we don't adhere terribly well. Will patients relapse? You betcha. The predictors of relapse are what you would expect to be the predictors of relapse. People who are HOMO2 dependent, people who have a poor social situation, people whose function at baseline is poor already. Okay, those are the people that tend to relapse. But they have bad disease, so it's not surprising at all that those are the factors much more predictive of relapse than are what we do for any individual exacerbation. So that is COPD. Any questions about COPD? Comments? Yes?
With the non-invasive ventilation, do you have any tips for mitigating the added anxiety that a lot of these patients have? Do you just give them a little vent?
Yeah. So the question is, non-invasive ventilation causes a lot of anxiety, and it does. And I recommend, if you have a BiPAP machine or a CPAP, BiPAP, by the way, is a trade name. It's not. It should be bi-level positive air, BLPAP. But anyway, if you have one of those machines in your hospital, I recommend that you find a private place, take it into the bathroom with you, put it on. I really, really recommend you do this once, because it is flippin' suffocating weird to try to breathe with that thing on. And it turns out that healthy people don't tolerate it very well. You don't need it, and it is uncomfortable for you. For people that are suffocating, getting them to buy in to that non-invasive is tough. What tends to help the best is to make the respiratory therapist put out their cigarette, come inside, get the machine, and stand at the bedside and work with them. And truly what tends to help people more than a drug is coaching, is getting them, and it takes you and or the physical therapist, respiratory therapist there, talking them through until they coordinate with the machine and trust that it's going to make them feel better. It's not going to suffocate them. And part of it too is it's worth experimenting with interfaces. Some people do great with the nasal. Some people hate that. Some people do much better with the face mask. That's kind of what they're used to. So you have to experiment a little bit with interfaces. Can you use drugs? Sure you can. There's always the pitfall of, oh, you could suppress their respirations. But think about most COPDers you've seen. They are, unless they're in CO2 narcosis and they're falling off the bed, they are anxious, sweaty, grabbing you, sitting on the edge of the bed. A little bit of Ativan, half milligram, that's not going to suddenly turn off their breathing. So if you need to go there, go there. A little bit of Versed, which is short-acting and nice, kicks in quick, that's a possibility. Yeah?
Does being on BiPAP, is that in and of itself a factor in where they get admitted to the hospital, whether it's ICU, or you go by more the usual other
Well, that actually, so the question is, I've done what I was told to do. I'm really good. I put them on that machine, and bummer, they want to stick them in the ICU. Well, that depends on your institution. And one of the things we had, and this is very institution dependent. So what we did at our joint is we said, look, ICU, schmICU, you are not putting this patient in an ICU unless there's another reason for them to be there. We have 4 to 8 bed PCU units with nursing staff. That is just fine to stick them in one of the, probably a monitored setting is worth it. If they were sick enough to get put on that thing, they're generally sick until they can get weaned off the thing. But they certainly don't need ICU care, unless there's another reason for it. Yeah.
The other thing I'd say that's helpful with the coaching is to kind of titrate them up. If you can start like at a 3 and kind of slowly.
That's a very good idea.
It's really nice to do.
She's mentioning that one of the things you can do is titrate them up, so start them at a little bit so they get a feel of what it's like, and then get them to the level that you'd like. And that's in contradistinction, by the way, to CHFers. What you'd like to do with it works great with CHF as well, and really what you'd like to do with the CHFer is hold the thing on their face, crank that thing up to between 15 and 20, and leave it there and make them breathe. Because it's shoving all that fluid back into the interstitium and out of the alveoli. And if you can get them past that first 5 to 10 minutes when they're already flailing and their blood pressure is 240 over 140, and you're trying to get the nitro on board and the ACE inhibitor, etc. If you can get them past it, you want to start them high. That's different, however, and you're absolutely right. You can titrate up depending how sick they are, and they may tolerate it. Any other tricks you guys use? It's great. I love this. Yeah.
What about its use, I'm talking about positive pressure ventilation, pure asthma?
Oh, positive pressure ventilation and asthma.
Somebody you're thinking of intubating, is there any data about it?
There is data on non-invasive ventilation and asthma, which is much more disappointing. Now, it is a bit scattered. There are 2 positive papers that I am aware of that are out there that said it helps prevent intubation. The group that seems to be helped with with non-invasive ventilation in asthma are the acidotic, but only the Goldilocks version, the sort of pH of 7.3 to 7.35 acidotic. If their pH gets below 7.3, they tend to not do very well. Same thing with CHF. They tend to be just too sick for it to do them much good. And the problem is that the airway that's constricted is way the heck down there. It's not a stabilizing of airways deal. It's way the heck down there. So this is not as helpful in asthma as it is in COPD or CHF or obstructive sleep apnea, or it's a great tool in somebody who's end stage something, who's a no code, that you'd like to get past this respiratory event. It's really a wonderful temporizer in that instance as well. Yeah, sing out. Should we be doing spirometry? Oh, that's like a whole separate debate, because spirometry is recommended everywhere you go. And in asthma, it's considered this absolute mainstay of how you decide what you do and how they're getting better, et cetera. And it is in research. I'm not sure it is in an acute setting. Part of that is to get good spirometry requires people who do it right both on the testing end and the doing the test end. And our staff, if your RT is really good at it, they're used to it, they can coach the patient through, and the patient can give you a good effort, then it's helpful. But you've all seen the I love the one where you'll say, spirometry to bedside and order FEV1 measurement. And they'll give it to the patient, they'll say, breathe into this. Okay, fine. And it's like, 2. The patient should be dead. So it really depends on how it's done. Can you use that? Yes, but it really needs to be done correctly. So it begs the issue of if the number you're even getting is good. If it's garbage in, it's garbage out. So I think at least in the acute setting, it's tougher. Chronically, probably you can. Not as much as asthma, though.